For our presentations, I have a list. We have approximately 8 minutes for speakers. First one will be made by Gözde Çolak. Are you here? Good morning, everyone. Briefly, I would like to introduce myself. I'm from Ege University, Psychiatry Department, and I am also a member of the SOCAD lab, which my professor, Dr. Ali Safet Gönül, is also a member. I wanted to present you a creative thinking in brain regions. I would like to talk about creativity and reasoning are complex cognitive processes, and their neural basis remains unclear. And our aim was with that study is to investigate brain connectivity related to creative reasoning using multimodal MRI. We took 30 healthy adults between 20 to 35 age, and when we were screening MRI, we have also made an analysis according to those results. And briefly, I would like to talk about the modalities of MRI that used in the study. MRI provides us anatomically high resolution screenings and makes us conduct our analysis easily, and during the task we can measure task risk brain activation with fMRI and RS fMRI. We can measure resting state functional connectivity. With the WMRI, we can get information about memory tracts. I'll talk about the knowledge-based reasoning task. All participants performed 120 trials across 4 fMRI sessions, and each trial showed 2 word pairs as left and right. The purpose of the participants is to say that if there's a similar analogy between two words, both had 2 buttons in their both hands, and one of them had a button that means there is analogy, and other one that means there is no analogy. It had 3 seconds inter-trial intervals. Each pair displayed for 9 seconds semantic distance of word pairs modulated task difficulty. I put a sample here. The analogies between Catalan France and Mozart and Messi. We asked if there is an analogy between those words. For example, while one of them is violinist, other one is a football player. I would like to talk about the findings. I mean, we have many findings that has details, but fMRI findings, especially in the left interparietal sulcus, anterior cingulate cortex, frontal part, middle frontal gyrus, right ACCV, bilateral caudate nucleus, had an activation increase. As we all know, the regions are also connected to frontal and reward-related areas. We also have a 3D representation there, and in this slide, during the task, cortical activation is on the screen. I also showed you the cortex activation, subcortical activations, especially in the left caudate nucleus and right caudate nucleus had activation, so there's a high correlance between those tasks. In resting state fMRI findings, especially in the left interparietal sulcus to right inferior frontal junction, we had a connectivity. And this one is a resting state functional connectivity image, especially, as I also talked about before, in the left intervertebral sulcus and right inferior frontal junction had a strong connectivity. In diffusion MRI, we had no global tractography. There was no significant correlations in global tractography, but ROE based results had left medial lower frontal cortex anterior cingulate cortex activation. And again, we also have an image like this. In the right part is really important. Creativity is actually a wide web in the parts of the brain. It's not limited to just one part. And as a conclusion, both functional and structural connectivity are important because they have role in creativity processes with we show that with tasks and the necessary data. Other than this study, we also see very little study about this issue. Thank you very much. And this is our SOCAT lab team, especially our Professor Dr. Ali and Jadash. I would like to thank them especially. Thank you very much for listening. Thank you. Do you have any questions? Okay. Our second presentation from Öztürk. Why Emrah is not here? Okay, say hi him for me. He will be presenting socio-demographic and clinical characteristics of the patients followed in the city hospital and OCD outpatient clinic. Today, we will present you a study that we have conducted in the Süleyman Yalçın Şehir Hastanesi Hospital OCD Outpatient Clinic. In this study, the individuals that are diagnosed with OCD, we have evaluated age, gender, education levels, marital status, working status, and income levels. Our study was retrospective archive document work. It was conducted between January 2020 and 2025. As I said, the environment is the OCD inpatients in Professor Dr. Süleyman Yalçın Şehir Hastanesi, City Hospital. And our ethical approval was from Istanbul Medeniyet University. And the information of socio-demographic and clinical and polyclinic follow-up information was received from the archived files. We have evaluated 158 patient files, and in the analysis we have preferred statistical methods. For categorical variables, we have calculated frequency. The majority of the participants were females, and when we check out the age group, females are mostly 26 to 45 years old, and the age median was 34.7. And about the education status, 75.3% is high school graduate, and the marital status, 64.6% was single, and when we check out the working status, active employees were 24.7, unemployed 50.6, and students 24.7. And the household income level was the biggest level was 1 to 3, minimum wage 63.3%, and above minimum wage is 22.3%. When we check out the parental history and childhood information, when we check out as a caregiver, mom and papa was both together 72.8%, relatives 4.4%, just mom 22.8%. Divorcing status, uh, divorce rate was 6.3, no divorce was 93.7, childhood violence 77.2, no violence, physical violence was 20.3%, and sexual violence was 2.5%. Smoking status, non-user 65%, and less than 10 was 19.6%, one pack a day 12.7%, more than one pack was 1.9%. Alcohol usage, non-users were 82.3%, rare, less than one per month was 14.6%, minimum level 1 to 4 to per week 1.3%. We also checked out other diseases that these patients had. We saw that endocrinological diseases were around 10.8%, and also they were diagnosed with other mental diseases. Again, obsession kinds were evaluated. 65.2% had a pollution obsession, 54.4% was doubt and control behaviors, and 54.4% was obsessed with unwanted thoughts. As they see, physical matters was 5.4%, collectionism is 18.9%. And we also checked out the complaints as well. Our argument in conclusion, the findings shows us that this OCD is a multidirectional disorder that is not only limited with psychopathology, individual psychopathology, and the participants were mostly women, and the education level were majority consists of high school or above. And the family history and childhood findings actually supports the developmental roots of OCD. The situation shows that OCD is not just about symptoms, it's supposed to be connected with the life history as well. Psychiatric comorbidities shows major depression mostly because OCD is directly connected to mood swings and disorders. So, diagnosis to be correct is very important. Both prognosis and the treatment process is very critical. Obsession kinds are very variable. There are many kinds in the literature. You can also see it. Obsessive behaviors like nail removals and skin picking, scraping. It is actually affecting heterogeneous and affecting many aspects of their life. Our study aims to provide contribution to this approach. Thank you. Thank you, Berra. Do you have any questions? Thank you. Our third presentation, Young Adult Autism Spectrum Program, Effectiveness and Adaptation. Hussein is not here. Who will be presenting? Welcome everyone. Good morning. Normally, Mr. Hussein was going to present, but this is a last minute change. It is like this peers is young adult autism individuals social skills program. So we are trying to transfer transform that into Turkish. Well, autism spectrum disorder is a neurodevelopmental situation. Since I am a young adolescent psychiatrist, we actually see the challenges that they have. So, in means of observation, this was a very beautiful study for me, especially in this age group. They had academical desire challenges. They had troubles about developing skills about independent living and having trouble understanding social cues and starting a conversation and having trouble continuing that conversation and making meaningful peer relationships. That is a major challenge for them as well. As we can see, this peers program is actually want to go step by step all those points. It's like a building, so it is structured like that. You can just go out of the content. You have to watch out for the minutes because the words there has to be respectively pronounced. The developer of this program actually specified that it was very critical. For 16 weeks, we have conducted face-to-face meetings with a young adult group and coach group in two different rooms, sessions that we conduct parallelly, and we do that every week. In those sessions, we do information sharing and conversation opening and continuing that conversation. So there is a didactic information in that sessions. They have role playing games, and in the end they have homeworks and they move on with the next week. And we also touch up on the point that how to find friends, in which environments they could find friends, and how can they reach out to those people. Should we use electronic channels or portals? Which ones are safe or not? This is very hard because they could be marked and they could be bullied, flirting, the manners. All those were taught, and it has that kind of sub headlines as well. And we actually did our application. Our project manager was Aynur Görmez. We also had PhD and master students. We have a very crowded team in means of project criteria, being between 18 to 25 years old, having a DSM-5, autism spectrum disorder diagnosis. Because despite this is important, it could actually disrupt with the connection of the group, and it has to have the specification of the challenges about the social skills of that young adult, and total IQ score supposed to be above 70. And the exclusion criteria, having a sense loss more than hearing. We conduct an invitation to the study, and then we conduct a first evaluation in detail, and it takes a really long time. At that session, we are assigning two groups, and we have two groups. One is a peers intervention group, and The other one is a control group. After 16 weeks, we conduct preliminary tests, and in the control group, we will be conducting another test in order to move on with the study again. So this is the test. After 16 weeks, we do the final test, and after 6 months, we do follow-ups as an observation, and we call them out again to check out in which status that we are in. In the pre-tests, we conduct with the eyes and SSIs, the social skill test. Again, it was developed by the peers team. It's actually testing the learning part of the deal, and this is social skill test. We saw that scores increased greatly, and in the autism survey rates were decreased, and it's increased in the intervention group. And again, in the young adult control groups data is in the slide right now, and in the intervention group, again, the scores of the autism spectrum surveys and empathy scale, as we can, so those are filled out by the parents and social coaches. Again, Miss Einer, the distinguished lecturer, Einer shared data yesterday when we check out the intervention group and the control group. And control group, we saw that depression rates in the surveys in the control group were better than the other group. We actually thought about that if we cause a negative relationship in means of depression, and we actually will include two more groups, and latest data will be shared next year, I hope. Thank you. Thank you very much.
Pınar'a sorusu olan var mı? Enteresan proje.
Are there any questions to Pinar, Miss Pinar? This is a very interesting project, actually. I also listened to it priorly, so when the results will come, I think we will see. Yesterday, Aynur Hoca mentioned with regards to adolescents and teenagers and kids and also adults learning the diagnosis and having insight on this can be in terms of a shock experience, but for the middle and long term effects that can contribute positively, and for them to see a group just like them, similar to them, is a contribution, of course, and so that they can change some of their behaviors, and this is a contribution in that sense. And this was discussed, and I don't think that that will constitute a problem, and I hope that we can do such a thing, and we can put such a thing in practice. And also for teenager, Izmir team is actually working on that. It's a TÜBİTAK project. Thank you. Congratulations. So the fourth presentation is regards the gastrointestinal bleeding, retrospective analysis of antidepressant use and its association with gastrointestinal bleeding in emergency department patients. Good morning, everyone. I wish everyone a fruitful Congress. I am Tayfun Özbek. I'm an assistant physician at the Bikent Provincial Hospital Psychiatry Clinic. So now I'm going to be providing you the results of our project. So with regards to the side effects, we will be talking about that in a minute. So for the background and aim of the study, I would like to give some information. For instance, the selective serotonin reuptake inhibitors are associated with side effects such as nausea, vomiting, abdominal pain, and diarrhea. And the aim of the study is to investigate the frequency of antidepressant use among patients presenting to the emergency department of our hospital due to gastrointestinal bleeding. So the methods of the study is the study was approved by the Ankara City Hospital number 1 Medical Research Scientific Ethical Evaluation Board on in 2024 under the protocol number label 1 to 24. So the socio-demographic characteristics are the age, sex, marital status, educational level, employment status, place of residence, the location of the GI bleeding, clinical course of GI bleeding, history of psychiatric diagnosis and treatment, presence of comorbid medical conditions, and presence of additional diseases that may cause bleeding, diathesis, use of antidepressant medication. Here you can see the results. So a total of 624 participants with a mean age of 60.4, including 47.1%, 2,094 females, and 52.9%, which is 330 males, were included in the study. The hemorrhage focus of the patients was as follows: 58.3 had upper GI bleeding, 39.1% had lower GI bleeding, and 2.6 had an undetermined hemorrhagic focus. Additionally, 24.2% of participants had a psychiatric disorder, and 16.7 were using antidepressants at the time of admission. Regarding the cause characteristics, we can talk about 43.6% of patients were discharged, 43.3 were admitted to the inpatient clinic, 2% experienced complications, and 3% left the hospital against medical advice, and 9.1, which is 57 patients that refused treatment. So when we look at the average age, 68, when comparing the characteristics of antidepressant users and non-users, the mean age was significantly higher in the antidepressant group, 68.7 versus 58.7, and the proportion of women was greater among antidepressant users. And there were no significant differences between antidepressant users and non-users in terms of hemorrhage focus distribution or cause characteristics, which is P greater than 0.05. When we look at the comparison of the characteristics of antidepressant users and non-users, the rate of comorbid conditions was higher in antidepressant users, which is 94% to 94.2% versus 76.6%, as was the use of medication that increased bleeding risk, 57.7 versus 44.1% is the comparison. The mean number of other factors, example, there are some diseases, extra diseases. So when we come to the discussion part, the association between selective serotonin reuptake inhibitors, the SSRIs, and gastrointestinal bleeding is well established. The SSRIs, especially those with strong serotonin reuptake inhibition, like fluoxetine, impair platelet aggregation by lowering serotonin levels in platelets, raising the bleeding risk, particularly when used with NSAIDs. And evidence indicates that the SSRIs more than double the risk of upper gastrointestinal hemorrhage, with the risk increasing over 500% when combined with NSAIDs due to serotonin depletion in platelets. SSRIs elevate bleeding risk through reduced platelet aggregation and higher gastric acid secretion. This risk is significantly increased when SSRIs are taken with other medications that affect hemostasis, such as NSAIDs, antiplatelet agents, and anticoagulants. The concurrent use of SSRIs and NSAIDs raises gastrointestinal bleeding risk by more than fivefold, with odds ratios ranging from 4 to 15, while proton pump inhibitors, PPIs, may offer protection. Further research on preventive strategies for high-risk patients is essential. Clinicians should assess bleeding risks and consider alternative treatments or gastroprotective agents for at-risk patients. We are talking about 16.7 for the patients that are coming to our clinic. So a case-controlled study demonstrated that the concomitant use of SSRIs and NSAIDs significantly increased the risk of gastrointestinal bleeding in patients not using acid-suppressing agents. And so in a study conducted by WHO in 20 countries, it was observed that AD use were 3.1% in the general population for the last 12 months. In our study, it was observed that antidepressant use was higher in patients with GI bleeding than in the general population. And this may suggest that AD use may contribute to the etiology of GI bleeding. However, it is important to consider that some risk factors, such as various chronic diseases and advanced age in these patients, increase the risk of both GI bleeding and anxiety depression. So this study emphasizes the importance of evaluating the use of antidepressants in patients who are experiencing gastrointestinal bleeding. It sheds light on the potential link between these medications and the risk of bleeding, which is crucial for clinicians. As a result, it highlights the need for careful monitoring and thoughtful risk management, especially for patients who may have other comorbidities and are using multiple medications. So, 4,000 is the scale of a patient group, and this was actually an exemplar. So, for the remaining patients, we want to be going through with the screening and then to have a much more detailed comparisons. Thank you very much. Are there any questions? Thank you. So for the fifth presentation, Aslı Kılıçarslan is going to be presenting to us the side effects of antidepressant medications, a 3-month prospective study. Good morning. So with regards to the side effects of antidepressant medications, we have a project a study that we concluded for the use of the antidepressants for 3 months. So we all know that different antidepressants have different effects, and the common side effects of different antidepressants typically emerge within the first 1 or 2 weeks of treatment, while some effects may develop in the following months. And the aim of our study for the first time is to prospectively evaluate the side effect profiles and medication adherence of different classes of antidepressants in patients undergoing treatment over a 3-month follow-up period. So we are actually trying to look up for which side effects are coming up in which months. So a total of 450 patients who required antidepressant treatment without appointments that are coming in actually, and initiated as single antidepressants were randomly selected and followed for 3 months. For each control, we had to follow them, we have to survey them. So the patients who did not follow through were out of this 450 patients group. All participants were administered Sosyodemografik data forms, the UK side effect rating scale, and the more risky medication adherence scale. And at each follow-up visit, side effects were recorded, and the scales were re-administered. And if there is a side effect that the patient was not tolerating, we actually got that patient out of the patient group. So a new diagnosis has been established for 56.9% of the participants, and 58.7% had no prior history of antidepressant use. The most common diagnostic category was anxiety and related disorders, followed by depressive disorders, which is respectively 47.3% and 19.3%. Escitalopram and sertraline were the most frequently prescribed antidepressants. So I'm going to pass these these slides quite rapidly because it's kind of long. And at the first control visit, the rate of psychic side effects was similar. And we have found this. The first three drugs with the most common psychic side effects were amitriptyline, atomoxetine, and clomipramine, respectively. So there were some patients with hyperactivity and attention disorder. And at the second follow-up, antidepressants were similar in terms of causing psychic side effects. And at third follow-up, there was no difference between antidepressants in terms of psychic, neurologic, or autonomic side effects. So at the first control, again, there was a significant difference in terms of neurologic side effects with these subgroups. The first there was a significant difference here. The first three drugs with the most frequent neurologic side effects were citalopram, paroxetine, and imipramine, respectively. And at the second follow-up and the third follow-up were similar results. And when at the first control, there was a significant difference in terms of autonomic side effects. And the first three drugs are amitriptyline, imipramine, and fluoxetine, respectively. Again, for the second control, amitriptyline and imipramine were found to cause significantly more autonomic side effects compared to other drugs. And for the third one, no significant differences. So at the first control, it was found that they were similar in terms of producing other side effects. The first three drugs with the most frequent other side effects were imipramine, clomipramine, and fluoxamine. Second follow-up is fluoxamine was found to cause significantly more side effects, and in the third follow-up, bupropion and fluoxamine cause significantly more other side effects than other antidepressants. So, what are those? The three most frequently reported side effects as at first follow-up were reduced sexual desire, emotional blunting, and nausea and vomiting. Antidepressants were similar in producing the side effect of emotional blunting. Venlafaxine, vortioxetine, and sertraline were found to be the three most common drugs causing this side effects. For the vortioxetine, I wasn't waiting for such a result, but it did. While venlafaxine, vortioxetine also again are causing nausea. So at first follow-up, while there was no significant difference between antidepressants in terms of reduced sexual desire, imipramine, bupropion, and clomipramine were the three drugs that cause the side effects the most. So for the second follow-up control, again, you can see at the second follow-up were reduced sexual desire, decreased sleep duration, and emotional blunting are the side effects. And we can talk about for emotional blunting, trazodone, venlafaxine, and escitalopram are the three active ingredients linked to that. So for the last control, there was a significant regression in the frequency of side effects at the last follow-up. No neurologic and autonomic side effects were reported. The most commonly reported side effect at the last follow-up was reduced sexual desire. So we have talked about 450 patients, and we closed up the study with 413 patients because there were some side effects, and patients had to switch the medications. We had to actually get them out of the list because we needed to do the follow-ups. I think it will be better to switch to the other slide so that I can continue more effectively. I just need to go back. So what is interesting here, it is not interesting, but it is comprehensible actually. So the side effects were reported to us at the second follow-up because, and we actually linked it to the compatibility with the medication because there had been some additions to the medications that they were taking. So medication adherence was significantly lower in the first month compared to the third month. So we interpret this as a positive result of informing patients about treatment adherence during outpatient clinic visits because we didn't actually give any information to the patients about the side effects at the beginning. But when side effects occurred and we informed them to the patients, after the third follow-up, we saw that the patients were informed about when they are informed about the side effects, the adherence was higher. So the level of functional impairment in daily life was significantly higher at month 1 compared to month 2. And in fact, although patients reported more side effects at the second follow-up, side effects in the first month had a greater impact on their daily performance. And we are actually out of time. Okay, I'm going to go rapidly for the discussion part. In the third control, there was significantly more causal assessment compared to both the first and second controls, so no significant difference was found in the first and second controls. So in other words, the psychiatrist found it more reliable that the medication side effect reported by the patients in the following months. So I'm going to pass these slides as we don't have much time. Emotional blunting is important. From neurological perspective, tremor and autonomic nausea and vomiting side effects. But what is actually missing a little bit in the clinical side of things is the emotional blunting. So I think that is important. So we have to actually follow these patients maybe on a much more long-term period. So even though these medication changes occur and we got some patients out of the list, that was actually accounting for 8.2%. But we think that then generally they can be tolerated. So thank you very much. I'd like to thank you.
6. Sözel otur.
For the sixth presentation, Selin Çiftçioğlu. Is she here? For the seventh presentation, Ali Tarık Altunç. Hello, I am Ali Tarık Altunç. I'm actually associate assistant physician at Istanbul University of Cerrahpaşa. Efficacy and safety of an accelerated deep TMS protocol targeting DMPFC with a double cone coil in treatment-resistant depression is the title of my presentation. So transcranial magnetic stimulation is a neurological modulation technique that allows non-invasive stimulation of the human brain. Had received an FDA approval, and there has been some transformations in this. So 30 minutes was the treatment duration. With the ITBS protocol being used, reduced to 3 minutes. So with the development of the bobbins and the dorsomedial prefrontal frontex being put into use, with one session to reduce to 3 minutes, there has been a possibility to have multiple sessions during a day. So 4 and 6 weeks of treatment periods with only one session during a day can actually be reduced to 3, 5, 10 sessions per day. So it is now possible to have the treatment in a much shorter period of time. According to a review published in 2022, there are 63 accelerated TMS studies in the literature. The number of daily TMS sessions used in these studies varied between 2 to 10. Which parameters should be used for optimal efficacy and acceleration is actually still a question mark, whether it is time between sessions, treatment dosage, number of sessions per day, total treatment days, and target brain region. So dorsal tal prefrontal cortex is the subject of many of the studies, and TMS studies are for considered to be applied for 2 times a day. So patients who apply to the outpatient clinic of Cerrahpaşa Medical Faculty, Department of Psychiatry, were diagnosed with MDD according to the DSM. 5 criteria were resistant to at least one antidepressant treatment. In our study, these were the criteria to be inclusion. So exclusion criteria is the contraindications for TMS. So when we look at the TMS procedure, the McVenture Mac Pro TMS device and Cool DB80 double cone coil were used. And the motor threshold with minimum TMS stimulus that produces a visible contraction of the extensor hallucis longus in 3 out of 5 beats, and treatment sites is 25.8% of the distance between the lesion inion, and of course the target stimulation and set intensity is also important, but it kind of is a painful application. So the waveform is 6 shots. There was a 50-minute break between sessions. 4 sessions were applied per day, and 5 treatment days. At the end of 5 treatment days, which is 20 sessions, if there's a accurate response, we actually ended the treatment. And 3 extra treatment days were put in practice according to the treatment response, which will be 30 sessions in total. So actually, we're talking about 3 more extra treatment sessions days. So especially for the Hamilton depression rating scale especially is used, Beck depression inventory used, Beck anxiety inventory used, Beck the suicidal ideation scale, and on day 3 BDI used. Day 5 for the ones who are following up with their treatments. The 3 scales are still continued. And also the patients were reviewed with Hamilton. So the study included 34 MDD patients who met the inclusion criteria. One of these patients dropped out of the study due to suicidal thoughts during treatment, one due to severe headache, and one without giving a reason. And the study protocol was completed. 30% of our patients were male, females were 67%. Average age was 51.52, and 61% of patients did not develop any side effects during the TMS. The most common side effect was mild to moderate headache, reported by 24%, and 9% increased anxiety. And we didn't encounter any life-threatening side effects. So this is the graphic of the mean average scale scores before and after the treatment. We can see that in all the scales there are some reductions, and they were statistically important. So this is the most important part of our study. These insisting groups responded to the therapy with 64.5%, and with the REMS with TMS, remission with the TMS was 51.6%. So here we can see with the Beck depression scale, the change in BDI scores in treatment responsive group. Towards the 3rd and the 5th day, there was a reduction, and then up to the 8th, there was more stability. So first month results of the treatment shows us 3 patients were lost to follow-up because they received the ECT within 1 month. 5 patients was not included in the analysis because 1 month follow-up after treatment was not yet completed. And it was determined that 2 of the patients who went into remission relapsed, and 2 of the patients who did not respond to treatment went into remission. Here you can see the changes in average HAMD scores over time in Hamilton. There is a slight increase, but statistically it was not so significant. So the responsive patients are shown on this graph with linear visuals. We can see there's a slight increase towards the first month. And for the non-responders, here's the graph. 2 patients did not respond. And at the end of the first month, response to the remission criteria. Our study is the first to use an accelerated TMS protocol of 4 sessions per day to target the DMPFC. The efficacy of 2 sessions per day to the DMPFC is higher than 1 session per day, but the difference is not significant. And the response rate of applying 1 session per day to DMPFC is 48.5%, and the remission rate is 27%. And indeed, accelerated TMS applications there is some efficiency increase that's also reported in other studies as well, prior studies. So there are 2 key uncertainties with accelerated TMS protocols. This is persistence of early response, and second, patients with different response curves. So these are important problems. In the study by prior colleagues, colleagues, the remission rate, which was 90% in the early period, decreased to 70% at 1 month follow-up. But in our study, response and remission rates is stable in our study. So there are some limitations. A small sample size, 31 patients is the size of the patient group, and this actually makes it harder to generalize. And the open label nature of the work, no control group, and no blind patient and applier. So thank you very much. So I will switch, I will pass to the next presentation because at 9:30 there's another session, so we have 2 more presentations. Doğan Can Demiz, can you please come to the floor?
Merhaba, ben Rize Devlet
Hello, I am Dr. Doğan Can Sönmez from Rize State Hospital Psychiatric Clinic. So investigation of the effects of depression and anxiety on sleep quality in patients under hemodialysis treatment, a single center experience in Turkey this is a work that we carried out. So as known, chronic renal failure, CRF, is one of the most common chronic diseases in the world. And CRF affects an average of 10% to 14% of the general population. CRF significantly impacts patients' quality of life, especially in its advanced stages requiring hemodialysis, and also socioeconomic factors are also contributing. In this patient group, there is depression, anxiety, and sleep disturbances. They are common in this population, further exacerbating their health outcomes. And according to current studies, 40 to 85% of patients undergoing HD report sleep problems. So the aim of this study, the study aims to explore the effects of depression and anxiety on sleep quality among HD patients and identify the demographic and clinical factors contributing to these associations. So this is a cross-sectional study that is conducted in a single-center HD unit in Turkey. The sample size calculation was performed using G-Power software as minimum 180. We actually the study sample comprised of 101 HD patients, receiving treatment for at least 3 months and 100. Age, gender, and marital status matched. Recep Tayyip Erdoğan University included in the study. So the Sosyodemografik Form, Hospital Anxiety Depression Scale, Pittsburgh Sleep Quality Index, Epworth Sleepiness Scale, Insomnia Severity is the collection tool. SPSS 26.0 is used. As a result of our study, we can talk about here we are talking about a very sociodemographic and clinical characteristics. When we consider these, they are marital status. This actually has an effect on sleep quality for single people. And smoking and HD session frequency is also another factor that is contributing to the sleep quality. When we look at the comparison of scale scores between hemodialysis and control groups, there is a significant importance statistically. So for the correlation, so the Pearson's for study variables, when the age is older, there are some sleep disorder linked to that, and the quality of sleep, daytime sleep is much more increasing, and sleep disorders are much more increasing compared with the age. So for the multiple regression analysis of PCQI, the marital status and HADSA, HADSD has some effect on these scores. So the high rates of depression and anxiety in hemodialysis patients indicate that these individuals are at serious psychological risk. It was observed again that anxiety levels increased as the number of weekly hemodialysis sessions increased. Poor sleep quality was found in our study is 79.2% of the patient, and this rate is consistent with the data in both national and international studies. Again, depression and anxiety negatively affect sleep quality. Sleep quality decreases with age. Deep daytime sleepiness and serious sleep disorders are more common in elderly patients. Worse sleep quality was observed in patients who smoked, indicating that tobacco use are an independent risk factor. Again, better sleep quality was found in marital status. So the study, as a conclusion, highlights the profound impact of depression and anxiety on sleep quality in HD patients. Psychological distress coupled with factors such as smoking and frequent dialysis sessions significantly contributes to poor sleep. These findings underscore the importance of integrating psychosocial support and mental health interventions into routine HD care. By addressing both physiological and psychological factors, healthcare providers can enhance the quality of life and clinical outcomes for HD patients. Thank you for your attention. Thank you for this quick presentation. So, Elif Beyzanur Polat, the floor is yours for the last presentation, please. Hello, I am from Marmara University, Faculty of Pharmacology. I'm a PhD student at research. I also work as a research assistant. So the title of my presentation is the investigation of the effects of agomelatin on lipopolysaccharide-induced inflammation in a microglial cell line. So these inflammation is actually seen in neurodegenerative diseases. Microglial has two categories, M1 and 2. So microglia-mediated neuroinflammation is a hallmark of numerous neurodegenerative diseases, including Alzheimer's disease, Parkinson's disease, and multiple sclerosis. Neuroinflammation arises from the activation of microglia, which under resting condition can polarize into either the pro-inflammatory M1 phenotype or the anti-inflammatory M2 phenotype in response to environmental cues. M1 microglia are associated with the release of pro-inflammatory cytokines contributing to a cascade of inflammatory responses that can ultimately lead to neuronal damage and cell death. In contrast, so the various disease-associated factors can activate microglia through pattern recognition receptors, such as toll-like receptors and the prunergic receptors, promoting a shift toward the pro-inflammatory M1-like phenotype. These activating factors include disease-specific protein aggregates, commonly seen in neurodegenerative disorders, as well as endotoxins like lipopolysaccharide. Moreover, recent studies suggest that depression may also induce M1 microglia activation. Once activated, microglia release pro-inflammatory mediators that can in turn actively activate astrocytes. The combined release of inflammatory and neurotoxic factors from both activated microglia and astrocytes may exacerbate neuronal damage. So in the study, as an endotoxin, we actually research for microglial activation, and with toll-like receptors can induce microglia. Here, the aim of our study is to look out for the effect of agomelia on these two receptors. So this is the important part of the study that I'm going to share with you. There are the two micro pro-inflammatory mediators that can in turn activate the astrocytes. So once activated, these microglia release these pro-inflammatory mediators. We use the MHMC3 culture, and we use this entetic study, and we have actually aimed for the agglomerate to come up with the toxic effects of it. And after the process, is there any toxicity that comes up? We actually wanted to look into that. And after that, we have applied the LPS to the cells. We gave them the agomelatine treatment, and we collected the cells and tried to see the inflammatory response. So at the end, we did an ELISA analysis and research for the cytokines effectively. So the results of the MTT assay are presented in figure 1. AGO treatment at the specified doses did not exhibit significant toxicity in HMC3 cells. However, when AGO was administered to cells pre-exposed to LPC, significant dose-dependent differences in cell viability were observed. Following the LPS administration, cells were treated with AGO for 24 hours, collected, analyzed for cytokine levels using an ELISA kit, and the results are presented in figure 2. LPS treatment significantly increased the IL-1 and the TNF levels compared to the control, while significantly reducing IL-10 levels. And compared to the LPS-only group, AGO treatment significantly reduced LPC-induced increases in anti-TNF alpha levels. Conversely, the AGO treatment restored IL-10 levels, which had been decreased by LPS exposure, that can be seen on the figure 2C. So, in conclusion, our findings have shown that the AGO can suppress LPS-induced inflammation by inhibiting the expression of pro-inflammatory cytokines such as TNF-alpha and IL-1 beta in microglial cells, and strengthens this effect by increasing the levels of IL-10 and anti-inflammatory cytokine. Further studies are warranted to elucidate the underlying molecular mechanism. So this study also was supported by TUSEPT with project number 32,662. And so we would like to also thank TUSEP for their support. And with this TUSEP project, we also put in application different proteins as well. And we had the possibility, we had as an objective to look out for these different proteins. So once again, thank you to SEP for their contribution as well. So this is the end of my presentation. We are actually at the end of this session.